Today our presentation is on urological consideration in pregnancy, and I'm Dr. Afnan. I have with me Dr. Kaval Naz as a moderator. So start with the urolithiasis in pregnancy. The pain resulting from secondary to urinary stone, the most common non-obstetric cause of hospitalization in a pregnant woman, and the incidence between 1 ratio 200 to 1 ratio 500 pregnancies. Pain, urinary tract infection, and obstruction secondary to urolithiasis increase the risk of preterm delivery, preeclampsia, and preterm premature rupture of the membranes. Multiporous seem to be affected more than primiporous. Left and right side calculi occur with equal frequency despite right side hydronephrosis predominance. Most of the patients with symptomatic calculi present in the second and or third trimester of the pregnancies. The pathophysiology of urolithiasis in pregnancy is the first is hydronephrosis due to combination of the mechanical and hormonal effect and hypercalciuria. There are two reasons for the hypercalciuria in a pregnant patient. That is, for first, we have in the previous presentation we have studied about the physiological changes and that the increase in renal plasma flow and GFR that lead to the secretion of increased secretion of sodium, calcium, and uric acid into the urine. The other is observed to hypercalciuria. The placenta increase the production of 125 dihydroxycholecalciferol, which lead to suppression of the PTH. PTH hormones which regulate the calcium level in the blood. In return, the gut absorption of the calcium is increases. These two potential changes is offset by increased production of anti-lithogenic substance in the urines like citrate, magnesium, and glycoaminoic acids. The clinical presentation is same flank pan.
Yeah. So basically the mechanism of the urolithiasis that the stone promoting and stone inhibiting both agents are secreted in increased amount in the pregnancy. So they try to maintain the pH of urine, but although they try to maintain the pH of urine, but still the pH of the pregnant patient is likely increase. It is likely alkalotic. So the stone that are more prone to form in the alkalotic pH will be also formed in these pregnant ladies.
In most common, the composition of the stones in a pregnant population is calcium phosphatase rather than because of the tendency of the calcium with phosphate is increased in an alkaline medium. Clinical presentation: flank pan macroscopic and microscopic hematuria, irritative loads, and in some cases UTI. In 28% of the cases, initially the pain, abdominal pain, flank pain is incorrectly diagnosed as a appendicitis, diverticulitis, or placental absorption, which later on diagnosed as a symptomatic obstructing urinary calculi. The choice of imaging modality in pregnancy for urinary stones is the first choice of investigation is ultrasound. Difficult to differentiate between physiological dilatation of pregnancy from uteric obstruction. 34% sensitivity and 84% specificity for urolithiasis. Doppler ultrasound, uteral jets, and resistance index. Uteral jets should be performed with caution in pregnant patients. In the resistance index, which measure the renal vasculature, And the other is vaginal ultrasound may be helpful in elucidating the level of the obstruction that is distal within the in distal ureter. This is the picture of resistant index on Doppler ultrasound. This can it also can differentiate between the physiological dilatation in a pregnancy and then the dilatation due to acute obstructed calculi.
Basically, it differentiate between the that there is the physiological dilatation of the ureter, or it is due to the any obstruction. As the RI and the urethral jet are so much different in these both conditions. RI usually do not increase in the pregnant patients without any obstruction. The RI between the RI of the kidneys in the pregnant patient and non-pregnant patient become the same. But if there is an obstruction in the kidney due to the stone or any other thing, then which will decrease the amount of the urine that are flowing through the ureter. So there will be the RI of that obstructed kidney will increase in that patient.
The other modality is the MR urography. It is reserved for the cases where ultrasound failed to diagnose, and stone are seen as a filling defect, a word signal. And smaller stone are difficult to interpret and can't differentiate between the physiological hydronephrosis and obstructive urethral calculus hydronephrosis. Here we have a picture of MR urography.
So, what is the most important diagnosis in the stone patient? How we diagnose? What is the gold standard investigation for the stone patient? G. Plain CT or CT urogram? So it is still controversial. Some studies say that the CT KUB is a gold standard. Some say that CT urogram. So what will be the harmness to the doing CT KUB or CT urogram in the pregnant lady? Radiation and exactly. So if we need to do the CT in a pregnant lady anyhow at any cost, so what precaution we will tell to the radiologist that what kind of CT you should do in this lady? Low dose CT scan. Sorry. चलो आगे चलो.
Intravenous urogram, difficult in differentiating delay excitation of the contrast associated with the physiological dilatation from that associated with obstruction due to calculus. And enlarged uterus and fetal skeleton may obscure the small stones.
So what is the physiological dilatation of ureter in the pregnancy? Why it happens?
Pressure effect of the fetus.
कौन बता रहा है?
Yes.
Pressure of the fetus, and the second
Mechanical and
what causes the progesterone to the ureter?
Hormonal.
Actually, this causes the muscle relaxation. Sorry.
Computed tomography, low dose CT have a higher positive predictive value, which is 95% improved diagnostic accuracy. Ultra low dose CT, low dose CT can be defined as a less than 3.5 SMV, and ultra low dose CT as a less than 1.9 SMV. Judicious use is currently recommended in the pregnant women as a last line option.
So in the journal, the CT is the gold standard, but in the pregnant ladies, it is the last line option. Mostly we have to do the ultrasound. So when we see the patient, pregnant lady in our emergency department, we ordered the ultrasound KUB, and if there is a hydronephrosis in the kidney, then we manage it accordingly. Rather than we find the stone, where is the stone, what is the cause of the obstruction. Once we just relieve her acute emergency, after that, once she done with her pregnancy, then we will evaluate her stone disease or other cause of obstruction.
Radionuclide renography. Renography delivers about 10% of the radiation dose of an IVU. Physiological dilatation can be confused with pathological obstruction in 10 to 15% of the patients. Radioisotopes is excited in the urine, and the bladder reservoir act as a significant source of exposure to the fetus. Therefore, patients should be encouraged to maintain high fluid intake and void frequently. So now coming into the management. First is the conservative management. 50 to 80% of the pregnant patients with symptomatic calculi will pass them spontaneously with hydration and analgesia. The preferred analgesia regime has been frequent small dose of morphine, an acid increased risk of premature closure of the ductus arteriosus and fetal pulmonary hypertension and should be avoided. Metabolic expressive therapy, smooth muscle relaxation may be proof of less benefit as already ureter are physiologically dilated. Tamsulosin and nephrodolepin use off label, not FDA approved in pregnancy. And a patient should be counseled. It is like it is not approved from FDA if you are giving advice to give tamsulosin or smooth muscle relaxant to a patient in pregnancy. Now coming to the surgical management, the debate is still on between PCN versus degestanting. So here are the advantages and disadvantages of the PCN and degestants for symptomatic calculi in pregnant patients.
So, what will be the advantage of PCN and what will be the advantage of the degestant in the pregnant lady? We mostly do the PCN, but there is also literature regarding the degestanting. So, how we go for the selection that this lady lead the PCN or this lady lead the degestanting? Say again or
Uteroscopy, URS, diagnosing a therapeutic safely employable. हाँ?
एक मिनट जी नादिया कुछ कहना है अच्छा ये तो सही फ्लैश होके उसको पायलोनेफ्राइटिस भी करवा सकते हैं ये कहीं और नहीं बोल देना फ्लैश करने का वेरी गुड प्रेग्नेंट लेडी में हम इंटीग्रेट कर देंगे सही अच्छा और बेसिकली जो है पीसीएन और डीजे दोनों ही किडनी की ड्रेनेज के लिए होते हैं लेकिन एक तो ये है कि डिपेंड करता है कि पेशेंट हमारे पास किस स्टेज में आई है इसकी प्रेगनेंसी के अगर अर्ली स्टेज में है उसमें हम डीजे डालेंगे तो हमने पहले ही यूरिन की फिजियोलॉजी पढ़ी है कि यूरिन इसमें हाइपर यूरिकोसीरिया और ये सारे कैल्शियम जो स्टोन फॉर्मिंग फैक्टर्स होते हैं वो ऑलरेडी ज्यादा होते हैं यूरिन में तो फ्रीक्वेंट इंक्रस्टेशन के चांसेस ज्यादा होते हैं प्रेग्नेंट लेडी में डीजे के तो अगर तो पेशेंट लेट प्रेगनेंसी में आई है और अगर उसको जो है वो पीसीएन नहीं और हमें डीजे का देना है ड्रेनेज तो हम लेट प्रेगनेंसी में डीजे दे सकते हैं क्योंकि उसमें बार बार फ्रीक्वेंटली चेंज करने की नीड नहीं पड़ेगी एज इंक्रस्टेशन के चांसेस कम है हम लोग पीसीएन ही करते हैं लेकिन पीसीएन के भी अपने डिसएडवांटेजेस हैं कि ये डिसलॉज हो जाता है ब्लॉक हो जाता है या कभी कभी इसमें भी इन्फेक्शन के चांसेस होते हैं और एडवांटेजेस ये हैं कि लोकल में हो जाता है हमें आगे असेस के लिए दे देते हैं कि अगर हमें पीसीएन वगैरह करना हो तो हम रेसिट्रेक से जा सकते हैं
URS, diagnostic and therapeutic safely employable, non-urgent URS best perform in second trimester. URS in a pregnant patient complication related to the urinary tract complication reported 8.3% and obstetric complication reported 4%. Use of low dose and pulse fluoroscopy combined with lead shield of the patient pelvis can reduce the total radiation exposure. Direct endoscopically visualize of the URS or ultrasound guided URS radiation free methods. The other modality is PCNL. Should be deferred until the standard PCNL, which is done in a prone position, should be deferred until postnatal, as it often requires prolonged anesthesia and radiation exposure. The modified PCNL, which is in supine position with ultrasound guidance and minimal fluoroscopic use, may be considered. ESWL contraindicated in pregnancy because of potential disruptive effect of the shock wave energy on the fetus, and that can lead to miscarriage. Open surgery remains a viable alternative. So, no. Pregnancy in women with the congenital urological conditions, the myelomeningocele, the severe form of spinal bifida, where the spinal cord and nerves are exposed to the gap in the spine and bone defect, leading to potential paralysis and bladder ball dysfunctions. It is challenging itself when pregnancy adds on, it becomes more challenging.
So, in the meningomyelocele, what is the effects on the bladder? Other than the pregnancy, if the patient with the meningomyelocele, what is her bladder?
Neurogenic bladder or what?
So basically, these bladders are the neurogenic bladder, and they are the flexing bladder. So if the already these bladders are the insulted, and then when these kind of patient get pregnant, so there is then other pressure symptoms on the pressure compression effect on the bladder due to the gravid uterus.
Impact on fertility. Have normal fertility, 70% have successful pregnancies after conception. Post pelvic surgery may affect fertility due to uterine retroflexion and adhesions. Patients with MMC are at risk of latex allergy because of the chronic catheterization and use latex-free condoms and IVD when counseling for family planning. A multidisciplinary team approach is warranted for the planned pregnancies. Neural defect 1 to 8% if one parent affected, 15% if both affected. That is, those desiring conception should be counseled about the neutral defect in their offspring. And female offspring are more affected than male offspring. And prevention, prevention of the neutral defect in recently is folic acid before pregnancy for 3 months and up to 12 weeks in pregnancy. Folic acid supplement. Impact on pregnancy. As we patient with MMC as a already compromised renal function, so there is a renal function loss in pregnancies too, that resulting in a complication like preterm delivery and growth restriction of the fetus. Urolithiasis, both MMC reconstructive surgery of the urinary tract and pregnancy increase the risk of urolithiasis. Ureter obstruction by gravid ureterus mechanical may worsen the pre-existing hydronephrosis in the later stage of the pregnancy in 20 to 28 weeks and need a careful monitoring during this period. Other complication is a stenosis of prolapse of urostomy and compression of the catheterizable channels, intestinal obstruction, compromise of the vascular perfusion of the diversion bowel segment, and metabolic complications.
So if the patient has undergone for the augmentation cystoplasty and now she has conceived, so what will be the plan for her future plan for the next subsequent months? What will be the effects on his augmented bladder and other his condition? No, not so much. And the augmented bladder has also the risk of the urinary stasis. They cannot empty their bladder normally, so there are the more chances of that. One thing is that again the urolithiasis, so that can also complicate the pregnancy. And then when these patients like get pregnant, so there should be the multidisciplinary team approach which involve the urologist, obstetrician, and the gynecologist. And these patients should be follow up in the multidisciplinary or tertiary care unit, so that their follow up could be the schedule. And the mode of delivery are these patients are really important. Chalo.
Driven by the past surgical history, ACM, BNR, unidiversion, and pelvic anatomy, is still controversial with many considerations. The preferred vaginal delivery should be considered contraindicated in the following MMC patient: narrow bony pelvis, BNR or artificial sphincter, contracted hips. Vaginal delivery should be performed with caution in following MMC patient: ureterosigmoidostomy, fetal malpresentation, uterine prolapse. Following concerns should be noted in those patients proceeding with C-section: intraperitoneal VP shunts, diversion pouches, and intracystoplasty or neobladder.
So when we are going for the obstetrician going for the cesarean section of the pregnant patient in the augmented bladder, what should be he or she care about in the augmented bladder? So in these patients, the mesentery of the augmented bladder is so important because the whole blood supply is coming from that mesentery. If they injure that mesentery, then the whole augmented bladder or the segment that are applied on that part will be the gangrenous or will be necrosed, and it causes the disaster effects to these patients.
Urologic malignancy during pregnancy. Malignancy during pregnancy is rare. Incidence is 1 in 1,000. Most common malignancy discovered during pregnancy is breast cancer, 1 in 5,000. Urological issue discovered during pregnancy are accidental or occurred as they present in an asymptomatic fashion. Imaging study for the evaluation of the malignancy, the radiation risk to the fetus must be balanced with the risk of the maternal health. Pregnancy does not change the biological properties or progression of the tumors. Renal tumors. The renal cell carcinoma, the most common renal tumor in pregnant population. Presentation is flank pan, hematuria, hypertension, and palpable mass. Pregnancy is not a contributing factor to the development of the renal cell carcinoma or progression of the renal cell carcinoma. Accurate imaging is mandatory with optimal use of imaging studies, ultrasound and MRI, or the choice of imaging techniques. Low-dose radiation CT can be performed. For metastasis, CT or MRI with contrast enhanced imaging is recommended by AUA guidelines. Get renal biopsy, mass biopsy if suspicious or on radiology findings. Management needs a multidisciplinary team approach. Treatment is same of the non-pregnant with nephron sparing, a radical nephrectomy, and timing of the proceeding depends upon the clinical status of the patient and trimester of the pregnancy. Systematic therapy should be avoided. Angiomyolipoma, second most common renal tumor, asymptomatic, primarily at risk of rupture in pregnancy. Benefits of serial imaging for women choosing observation outweigh the fatal risk. Treatment of choice is a transarterial embolization. Post-embolization syndrome can lead to premature labor. Bladder tumors are very rare. Most predominant is uterine carcinoma, which are most are non-muscle invasive, present with hematuria, misdiagnosed as a vaginal bleeding in 22%. Management with cystoscopy combined with upper tract imaging. TURBT can be done safely at any time. Non-muscle invasive bladder cancer, further management should be delayed until after delivery. So here we cannot adhere with the IUA guidelines for the management, which is the management for the non-muscle invasive. Muscle invasive bladder, no clear treatment strategy present. Definitive therapy with neoadjuvant chemotherapy and radical cystectomy may be the right for the situation. So the last management of UTI in pregnancy.
जी
muscle invasive bladder tumors में it's mandatory to do radical cystectomy within 3 months और इसका कोई नमल बदल नहीं है. For that, these patients have to be counseled in detail with family, and termination of pregnancy and then radical cystectomy is mandatory because this is life-saving. No other alternate, according to guideline, is suitable for that. Non-muscle invasive disease can be temporarily managed with cystoscopy, TURBT if feasible. Otherwise, if it turns out to be muscle invasive or high grade disease, then family counseling and termination of pregnancy is warranted for this. And then decision will be of the patient. One thing regarding augmented bladder, there is difference between just catheterizable channel formation or catheterizable enema channel or continent pouch. These all are not much producing much difficulty in gynecological obstetric surgeries because there is a window for that surgery. But in augmented bladders, there is no window because gut and bladder are culting over to the uterus. They are coming anteriorly, and all surgery to approach the uterus is from anterior. Mesentery coming from upward, then in between it's gut piece, and then lower down is primary bladder. In augmented bladder, this is much difficult, and I think if functional team have some experience, then they can share about it. But whole front of the uterus is covered by mesentery, gut, and then bladder. So there's much difficulty to deal with it surgically, and gynecologists always try to deliver transvaginally in these patients. And when augmentation is warranted in female, this should be considered in mind that this lady can in future go for pregnancy, and then C-section can lead to much trouble. So vertical approach through the mesentery can be offered in that situations because you can't just remove bladder and mesentery and all that, because in vertical incisions in mesentery, there will be less risk of future ischemia to that gut piece. Mesentery has an advantage over the surgical aspects because there is frequent anastomosis between these arteries which are ending into the gut. So because of that anastomosis, some piece of mesentery can be compromised for that surgical aspect. That's why no much risk of future ischemia. Dr. Afnan, Dr. Naveed is there.
Nice.
Okay, then continue.
Continue करें अफनान.
Management of UTI in pregnancy. UTI is defined as the presence of 1 lakh organism per ml of urine in a symptomatic patient, or as more than 100 organism per ml of urine with accompanying pyuria in a symptomatic patient. Diagnosis of UTI should be supported by positive urine culture. Asymptomatic bacteriuria is identified in 2 to 7% of the pregnant population. Patients with asymptomatic bacteriuria are at risk of developing upper tract and lower tract UTIs, which may negatively affect the fetal outcome. Patients should be screened for asymptomatic bacteriuria, and positive culture should be treated. Untreated asymptomatic bacteriuria progression to pyelonephritis is 15 to 45%. A treatment of symptomatic bacteriuria, the antimicrobial agent selection should be made in a multidisciplinary care. Generally, beta-lactam antibiotic, ampicillin, and ceftriaxone are safe throughout pregnancy. Nitrofurantoin is an alternative to penicillin allergic patient, and it should be stopped at 35 weeks, as it increases risk of hemolytic anemia. And the acute pyelonephritis should be patient with diagnosed with acute pyelonephritis should be hospitalized and treated with administration of IV antibiotics based on the urine culture and sensitivities. So, thank you.
Any questions? Any question regarding the urological condition in pregnancies?
Anyone have any experience of going into a gynae theater, or in sometime usually what they do in transplant patient maybe hota hai कि once there is a pregnancy and they need a C-section, they call us for a patient who is undergoing for C-section in a transplanted kidney. Usme bhi एक bladder and the kidney is very exposed to the uterus, and we need to take care of bladder to prevent the bladder injury and the graft as well, to go for a C-section. But in augmented bladder, I haven't any experience of it. Dr. Abbas, I think Dr. Faraj is with us, and he had much experience with Murli Saab. He worked with the team, so he may have a bit experience of these patients, how they counsel these patients for a future pregnancy and how they deal afterwards. Because pregnancy usually had very different vast disturbance with
I myself, I haven't been in the theater during. There was 2 cases that we were called, but Mulli Saab was asked Dr. Abbas to go. But when I inquired with Dr. Abbas, he told me that once the gravid uterus is enlarged and the fundus of the uterus usually push the mesentery a little bit to the right side. So the C-section incision should be a little bit higher, and the approach should be from the fundus rather than a little bit down on the usual C-section. So Abbas told me that the mesentery was a little bit pushed laterally to the right side, and there was a sort of clear area in over the uterus on the in the upper part of the uterus in the fundus side. But I myself, I haven't been there. Usually, such patients, they come to our clinic. Usually, we try to ask them not to conceive. But if it is necessary, the gynecologist usually try to ask them for normal vaginal delivery first. Then, but if it is necessary, that we ask them to call us whenever we the time of the delivery, and it should be elective procedure, and the urology should be available at that time during C-section. So Dr. Abbas usually goes from our side, and he has attended around 2 cases. But he told me that the mesentery usually is pushed a little bit laterally once the gravid uterus is enlarged. and there is a sort of area that we can deliver the child from that area.
Okay, thank you.
Yes, Dr. Yes, Dr. Usman.
And sorry, I'm adding in transplanted patients because whenever gynecologists do emergency procedures or emergency C-section or in other type of emergencies when there is much bleeding, then they approach through iliac vessels. That's why they also have fear of these vessels, announced most over external iliac vessels or sometimes internal iliac vessels. And this is also a consideration in these patients as well. That's why they call transplant surgeon.
Any other question or query? Or conclude करें. Yes, conclude करें.
So,
Question पूछ रहा है जी उस्मान.
I wanted to add one point regarding regarding the discussion. By convention, we do load segment C-section. So the benefit of load segment C-section is that there is less chance of uterine perforation in the later pregnancies. But if we have augmented bladder and the pelvic surgeries or these sort of complicated scenario, so in such cases, the gynecologists, they do upper segment C-section, they do from fundus. The drawback of that C-section is there is more chance of uterine perforation in the next pregnancies.
Upper segment cesarean section doesn't mean fundus of the uterus. It means higher, as possible, as much possible as safe for bladder. But bladder is not priority, and if there is consideration of future risk of pregnancy, then bladder, even augmented bladder is not pregnancy. That is repairable easily.
any other question and query?
Conclude.
Okay, thank you. So in our emergency, we usually encountered with mostly the hydronephrotic kidneys. So we have to deal very cautiously as we are dealing with the two lives. So if the patient in the sepsis or in any other severe pain or intractable, so we have to deal that emergency in a proper judicious way that either these patients need conservative management or any urinary diversion.